Hey, welcome to Spine Conference. Today's April Fool's Day, but I'm not going to be saying any April Fool's jokes. So we'll just get started. Just a second. Okay, so this is not the patient, but he looks sort of similar to this man. This is a case. I like going through cases because when you go through cases, you understand disease processes well. It's a 68-year-old man with a chief complaint of right lower extremity pain. He has had a previous L2 to L4 laminectomy in 2014, so 2 years ago. And he had very good pain relief, and the surgery went fine. He had an L2 to L4 laminectomy for back and leg pain. But then he started having recurring symptoms about 3 or 4 months post-op, and he kind of, like a lot of Harford County guys, he just toughed it out. He didn't feel like dealing with the whole medical process. He's like, I'm just going to just tough this out as long as I can. But then his pain became so bad that it started around 3/14/16, right thigh pain and leg pain. It was so bad he couldn't even walk with his walker. So this man usually walks with a walker. He couldn't even walk with his walker anymore. He went to the ER and was evaluated. His past medical history is insulin-dependent diabetes and Crohn's disease, and he's on a Crohn's disease medication, which I don't know the name of it, but it's an immunosuppressant, basically, for Crohn's. So his chief complaint is right thigh pain, mostly in the hip and the lateral thigh to his knee, and he cannot walk, and he has weakness, severe weakness. So any questions about the history so far? Anybody?
Where did he have the laminectomy?
Where? Union Memorial Hospital. So he's a man that escaped the clutches of Upper Chesapeake and went to the city for better care. But he was very happy with everything. Why he chose Upper Chesapeake, I don't know. And a lot of people in our county don't want to stay in the county for health care. They want to go into the city, kind of like Manhattan. They want to go into the big city for care. So on exam, he's 5'8" and 270 pounds. So he's a very large man, very muscular, and he keeps his hip on a pillow, his leg on a pillow, and he will not move it. It's extremely painful, very, very painful. His hip flexors are 1 out of 5 motor, so it means just a flicker. His quadriceps are 1 out of 5 motor, just a flicker, and his right ankle dorsiflexions are 2 out of 5 motor. So his right leg is basically useless. So any questions so far? Okay.
Minimal surgery that he had?
Yeah, I'm going to go over his surgery.
Full surgery would require fixation or grafting or something.
We're going to go.
He didn't have that.
He had a lumbar laminectomy. I'm going to go over that in detail,
okay.
though. Okay, that's important. So this is so he has 1 out of 5 quadriceps. So with basically, I want to go over quadricep strength. Without a quadriceps, you can't. Who wants to talk about the function of the quadriceps here? Anybody? Can you walk without a quadriceps?
No.
You can't. You can't. So every single, see this woman here, when she steps on her, when we walk, we have single leg stance. When you step on one leg, you can't do that without a quadriceps. Your leg will buckle and you'll fall. So at no point in time can you have single leg stance if you don't have a quadriceps. So you can still walk. Basically, you'll see these people, if you look carefully in the mall, you'll see these people. They're usually Indian because they've had polio. They put their hand on their knee every time they step on their leg. That's a quadriceps deficient gait. That's a strong person who keeps walking. So some people just quit walking, but yeah, you put
their hand up here and just kind of push back.
Yeah, you push. They push back on their thigh.
They always get their hand in their pocket. And they kind of
Right. So it has to be a very strong adult,
Yeah.
and kids will do it. I mean, kids, they have like the grace of God. They just keep going, and kids will just figure it out right away. They're like, they just put their hand on there and they just keep walking. They don't care about they're disabled. Adults sometimes, if it's a good adult, they'll keep polio, yeah, and that's because they learned it as a child. But as people get older, they don't adapt. Like adults usually don't adapt very well. So it's very important. And of course, the quadriceps is 4 muscles in the front of the thigh: femoris, lateralis, medialis, and vastus medialis obliquus near the knee. So this man's pain was anterior thigh and lateral thigh, consistent with the L2, L3 nerve roots sensory-wise, and myotomal-wise, it's L3. The quadriceps is mostly L3, but the quadriceps has multiple innervations because it's so important. It has some, I think it has some L2 and it has some L4, but mostly L3. And his quadriceps is out. Now, because it's out because of pain or because of dysfunction, it's not clear. So it could just be because he has pain, he won't move his leg. It's hard to say. So he had a lumbar laminectomy. So a lumbar laminectomy, that's an axial cut of the spine. The circle is the dura, the thecal sac, and his entire lamina was removed. So it's the standard, maybe not standard, but probably standard way to decompress the spine, the old way, the laminectomy way that's been, for how many years, 70 years or whatever. So basically you remove the posterior spinous process, the lamina completely, all the way out to the level of the pedicle, and you remove the whole thing. And it decompresses centrally. Now this weakens the spine, and the spine can collapse further after this. That can happen. Not always, but it can happen. So this decompressive technique has been refined over the years. And it's been refined in steps. So the first step is just there's two ways to call this: either porthole, which is the way it was originally described in 2000, and now some people call it in the neurosurgical literature interlaminar fenestration technique. And the posterior spinous process and the lamina are kept intact, and you just open up the area all around the facet where the nerves are compressed, but you keep all the bones intact. And the bottom left guy is my former partner, Charles Edwards, who taught me the technique when I was at University of Maryland. And to the right is one of his fellows who wrote this article, Klingman, on the porthole technique. It's also called, it's been renamed, like a lot of things in the world, it's been renamed and rediscovered by the neurosurgeon discovered, and it's called interlaminar fenestration technique. And that's more popular, probably because it sounds more serious, like a porthole. It's hard to say. So then it's further refined. So laminectomy is on the top right. You see, remove the whole lamina, and the bottom right is porthole interlaminar fenestration technique. And it's been the decompressive technique has been further refined to the left one, which is what I usually do: is unilateral laminectomy, bilateral decompression, and through just a hole on the left side, you can open up the whole spinal canal. And you may say, well, why didn't they do this before? How are we capable to do things through holes now? It's because our microscope is a lot more powerful now. The microscope is very agile, and the lighting source is very good, so it makes this possible. So we do surgeries through holes now more. Before, we'd have to have these huge incisions and huge lights to get the light into the incision. So any questions about decompression? So he had a full laminectomy, L2, L4.
So when you do the full laminectomy, spinous process is gone?
Spinous process is gone, lamina is gone.
So what's protecting posteriorly the spinal canal?
Just God protects it. You don't really need protection. So the muscles, it's really deep. It's like,
Yeah,
it's 5 inches deep, and there's muscles and things that are over it and fascia. It's really deep. It's hard to get, even during the surgery. It's a very deep structure.
Okay.
But the problem is the muscles have. This is my personal theory. I don't know if this is true or not. But my personal theory is the muscles have no bone to attach to, and because of that, the spine collapses. But I think if there's bone to attach to, if the muscles scar down to a bone in the posterior lamina, it doesn't become unstable. And the reason I say this is because laminoplasty, which is posterior cervical laminoplasty, which is a proven very good technique, and the cervical spine works. But posterior cervical laminectomy does not. And the only difference is there's a bone there. So if the muscles have bone to attach to post-op, the spine remains stable. That's just a personal theory of mine. No one's ever said it before. But I'm just trying to think, why do laminectomies do poorly? So when this man came in, he had horrible leg pain on 3/6/16. So they did x-rays of his pelvis, x-rays of his femur, x-rays of his veins. Everything was normal. So basically they couldn't send him home because he couldn't walk. So they just admitted him, and we'll just call somebody else, see if they can figure it out, basically. So when I saw him as a consult, I ordered an x-ray and an MRI of his lumbar spine. And this is the x-ray of his lumbar spine. And and so an exam, when I push his leg and move his leg, I don't think it hurt. Well, what do you see on the x-rays, Aaron?
Decreased disc space at every level.
Yeah, and a slight curve to his spine. Right, you can't really see because of his body habitus. You cannot get a good x-ray. He's too big to get a good X-ray, or maybe he wasn't staying still. It's hard to say. What do you think, Dr. Harold? Do you have anything to add about the X-ray?
Let's see, like mild retrolithesis L2, and I mean one and two is like pretty much bone on bone.
Yeah, the disc is
So
basically
they're pretty
gone.
much almost like trying to fuse themselves.
Sort of, yeah.
anteriorly.
Big spurs, anyway.
Yeah.
So, so this is an MRI I dug up from 2014 that he had 2 years ago. So it must have been, he had an MRI maybe a couple months after his surgery. So if people get MRIs, it tells you something's not right. It's not like people who feel 100% don't go to the doctor and ask for an MRI usually. So something was going on back then. And it shows that centrally, you can see the spinal canal is open. You can see the nerve roots have plenty of room. And here there's plenty of room, right? But he was still having some kind of problem. And we'll get
About the indentation of,
yeah, the discs. So you see the discs are bulging backwards towards the center of the spinal canal. And that's that same indentation that you saw right here. But because now there's nothing behind it, there's plenty of room for the nerve roots. But his problem is in the foramen. His problem is in the hole where the nerve exits. It was still compressed. Now you can still decompress the foramen somewhat from a central approach, but you have to remove the whole facet to really open up the foramen well. And I'll show you what I'm talking about. So his pain was so bad that I saw him and I actually scheduled a surgery, but he came back, he couldn't walk, and I wanted to make sure I wasn't missing something. So basically in orthopedics, when we are unsure of ourselves and we can't get a good physical exam, we get a bone scan. And I learned this from an article once about babies, trauma to babies. Babies come through the ER. It was an article, I don't know, 10 years ago that I read. When babies come to the ER, you can't talk to a baby. You know, they're crying. They can't give you a history. So sometimes they just do a bone scan of the baby and to see where the fracture is, because you can't examine them and they can't cooperate. So this man was sort of like that. He couldn't talk to me very well anyway. He was always confused on medicines. He couldn't explain himself. So I just said to myself, I'm just going to do a bone scan, make sure this man doesn't have a pelvic fracture, a hip fracture, a thigh bone fracture, something else that could be causing such severe pain, because it was out of the ordinary. Wouldn't you say, Aaron, how bad his pain was? Like, extremely painful. And I'll go into why it was so painful. So his bone scan was negative. I just want to show you a normal MRI. This is a sagittal cut. You see all the vertebral bodies, the squares, the discs, the spinal canal. L5S1, you see how big the central area for the spinal canal is, a big circle. And the foramen is where the nerve exits right here. Now you can understand that if you have some kind of process in the foramen, that can hit the nerve. Inside the foramen lives the nerve. So here's L4, L5, L3, L4. This person had a slight left side L3, L4 foraminal disc herniation, which was extremely painful. L2, L3, L1, L2, T12, L1, T11, T12. So this is normal anatomy. Now here's this man's myelogram. And do you think this is easy to interpret or difficult to interpret, or hard to interpret, right? Because he's so big, you can't really get a good X-ray on this guy, and also you can't get an MRI scan on this guy. In fact, you can't really image him very well. Even the CT myelogram is not great. So here's the axial cuts of the CT myelogram, and again, you have to. Good morning, Doug. Yeah, today's case is a 68-year-old man with severe right thigh pain. Severe right thigh pain. He's had previous laminectomy. So you can see the previous surgeon did a good job centrally. The spinal canal centrally is wide open everywhere. And yet this man can't walk, which is a serious problem. So what his problem is, his foramen is stenotic. And if you look at the frame, if you look at this foramen right there, at L5S1, right, it's open.
Yeah.
Now this is on the right. So we're like detectives. We have to look at every foramen and see which one's wrong. And of course, in our mind's eye, we know that his pain is right thigh, so we're looking for the right L2, right L3, right L4 nerve roots, because clinically that's our suspicion. And you can see 4-5 is stenotic. You can see the foramen is stenotic at 4-5. Mm-hmm. And then same thing at 3-4. It's stenotic. I mean, it doesn't look that impressive. And And the reason why it doesn't look impressive is you cannot see the foramen on a myelogram because the dura becomes perineurium at the level of the foramen. So the dye doesn't go into the foramen. So it's for foraminal stenosis, a CT myelogram is not a good test. And 2-3 is extremely stenotic. See that? There's no room at all for the foramen. There should be a hole. There's no room at all for that foramen. And there's no good way, and here's L1, L2, that's stenotic too. See that? No room for the foramen. And T12, L1 is normal, so you have a huge hole.
Look at that.
You could drive a truck through that, right? So this is the sagittal cuts, and this is the best. Again, this man is a big guy. He's had massive osteophytes. He has a deformity, so it's hard to get a good image in this man. But you can see this. This is his hole at L2. Look how tiny it is. It should be big like that one. And L3 is pretty small. L4, but it's hard to see. It's hard to see completely. And here's a coronal cut. And you can see on the right side here, he's compressed. He's because of his scoliosis, he's compressed, and he has these massive spurs. So his problem is foraminal. So this is a case in spine, and you can see here where the laminectomy is. He's had a full laminectomy. So you would think that he'd be okay after having this full laminectomy, but the problem is his foramen's compressed. And why is that a big deal? I'll tell you. You have to understand the anatomy. Basically, the nerve roots at L1, L2 become a cauda equina. The spinal cord ends there, and it's just cauda equina, just nerve roots. And between each pedicle, a nerve root exits. And the spine, you see where Crystal's eye is, that's the central spinal canal, where the spinal cord runs. And then where the pen is, that's the foramen. And a nerve exits each foramen. And why is the foramen important? Well, that's where the dorsal root ganglion lives. So the dorsal root ganglion is basically cell bodies where basically the nerve roots interact with each other. And here's another view. You can see the foramen. The dorsal root ganglion is this bulbous structure here that has cell bodies. So it's not a nerve. Like a nerve, a peripheral nerve can suffer pretty decent amount of trauma with not a lot of pain sometimes, but at some point it does pain. But if you hit a ganglion, it's extremely painful. And here's another just an idea of the schematic of the dorsal rootlets go into the dorsal root ganglion with their cell bodies, and inside the cell bodies are neuromediators that cause pain, and it's extremely painful. So this is just another opening of this, a view of the spinal cord, and you can see all the little rootlets coming off the spinal cord, dorsal rootlets, and then going into the joining together into the foramen. And right here, this is the covering of the dura right there. The dura, and inside is spinal fluid. But this dura connects to the nerve right about here and becomes perineurium. So when you do a myelogram, the myelogram stops at the foramen, so you can't see if it's stenotic. So you have to know this, in your mind when you're trying to understand problems. And you can see how it's a bulbous structure there. And because it has a lot of pain fibers, it has myelinated and demyelinated and cell bodies. So this is a histology of the dorsal root ganglion. The big circles are cell bodies, and when they are compressed, it's extremely painful. They're full of pain. It's just really painful. I don't know why. There's a reason. There's they're demyelinated. They have a substance P factors. It's extremely painful. So he had a laminectomy, but to get this just shows you why you have to fuse it to really open up the DRG well. Is you can see where the DRG is right here, but to fully open up the whole thing, you have to remove all this bone, and if you remove all that bone, it becomes unstable. So you have to fuse it basically. So this is one more. It shows you on the left, you can see where the nerve root is in the foramen, and again, it's very, very, very sensitive, and we have to open that up, but it's right next to the facet where the bones are together. So to totally open that up, you have to take out the whole facet. So you have to fuse it. So just in general, in medicine, we want to do the least amount. Like first, do no harm. We want to do the least amount to help people. But in this case, you can't do just a laminectomy. You have to fuse it. So any questions about? And the other interesting thing about this patient is I could never prove where the problem was. I had to use just thought. And surgeons, we never like just using our brains. You know, we like to see things and just do it. You know, and you know what I mean. But like as a I have to be sort of like a medical doctor where I have to go on my intelligence and my education and make a serious decision, which
Well,
makes.
you know where his pain is, so that tells you a lot.
But I never saw it. I never proved it, which makes me uncomfortable because I'm a surgeon. So we like to prove things with numbers and tests. But just to go on our education is hard for somebody like me.
Ask you a question about
Yeah.
anatomy. The further down the cord you go, the more of an angle the spinal nerves come out, right?
Yeah.
I mean, so does that make it more difficult?
No.
No.
No. It's just. Doesn't. I know it's interesting, but it doesn't really affect. Practically, it doesn't affect much, except under the microscope. It does a little bit under the microscope. You have to understand where things are, but that just takes a long time to know. In your mind's eye, it takes a long time to know where things are, because you're doing work so magnified. It's different. It's like a different world almost.
Now, disc compression failure would also cause some pressure on the nerve that you're talking about.
Absolutely.
You
So
see that in this picture right here. On the left?
absolutely. So a disc in
And he's had
the.
a lot of compression.
He did.
Loss of and posterior herniation of the disc.
He did. He did have the disc, and he had osteophytes, and he had a curve. It's kind of like a triple whammy. Yeah.
Going back to his history, he had the laminectomy just a few months and was good?
2 years. 2 years ago.
Okay.
And his wife said for 3 months he was good, but then he went right back to where he was. But he kept toughing it out. He wouldn't see
Okay.
the doctor.
Laminectomies are commonly performed, so is this a common after a complication?
Yes. Yes.
It is.
Yes. But most doctors don't do laminectomies, and most doctors do fusions, basically. Most surgeons. And why this man didn't get a fusion, because I know the surgeon who did surgery. I mean, it's not like he's shy about doing fusions. It's just a really big surgery for this guy. The fusion is difficult. He's big. He's deformed. It's a big case, and it's not an easy one. So I mean, I think it's
You know,
very.
you said he was 68,
Yeah.
so age and bone density, doesn't that play a part? Maybe is that why he?
His density is fine. Usually these big old dudes, they have very strong
Yeah.
bones because they're carrying around a lot of weight and they're men. Men usually maintain their bone strength. I'd say until, I mean, this is just practice, 75 when you say Aaron, because we're cutting on people. We know how strong their bones are. 75, 80, 80-year-olds start having weak bones, unless they're a farmer or something. So any other questions about what's wrong? So in my mind, it's very clear that his foramen is stenotic, but which one, I wasn't sure. I wasn't sure if it was the L2 foramen, the L3 foramen, or the L4 foramen. And so I had to fix them all, basically, to be sure. So his surgery, this is kind of a schematic of the surgery, bottom right. I did a revision laminectomy, and I fully opened the nerve roots, L2, L3, L4 nerve roots, so that I can see them. And then I did an instrument fusion from L1 to L5. And the case was a big case, 5.5 hours, 1 liter blood loss, a moderate size. We gave 375 cc's back. And Aaron, tell them what it was like to find the nerve roots, so people don't think I'm lying. Somebody else saying. What was it like? 'Cause she was there.
It was difficult and painful.
Yeah, and they're very deep, right? And they're very buried. And it took a very long time to open them up. But we opened them up. We were sure that they're open. And so you have to fuse this guy, because if you don't fuse it, it will just collapse right back. So he was fused from L1 to L5, and I used bone morphogenetic protein. And then I got a CAT scan just to see what the frame is, a little bit of curiosity, and also to make sure the screws are in good position. And you can see here the framens are, these are the right framens. The framens are open. They don't look very impressive on the CAT scan right here, but this is open now, and that one obviously you can tell it's wide open. But this is open. That one's open. And the other thing I found is that MRIs and CAT scans, they don't tell you the whole story. They just kind of like help you understand things. but they won't. Sometimes they don't tell you the whole story. You have to. And Aaron and I know with 100% certainty that we opened it up. We were looking right at the root. And it took us about an hour and a half, right, to open up those nerves. Just to open up the nerves took us an hour and a half. After we did everything, just to open up those holes took an hour and a half. But still, the CAT scan doesn't show it, which just goes to show you that these CAT scans only give you so much information. But you have to use your knowledge and understanding to interpret, this study. I mean, I know these things sound obvious, but
No, they don't sound good.
it's
When you say open up, are you opening up like the lateral recess, or are you just shaving?
the framing.
You know,
framing.
Just the frame. You're just basically making a bigger hole in the
Well,
floor.
full laminectomy and just open up that frame, but there's so much spurs. It's like
Yeah.
digging out a piece of spaghetti in a brick. It's very difficult. So what you do is you find the very top of the piece of spaghetti, and you follow the piece of spaghetti all the way out
Yeah.
by drilling away all this bone.
Dang.
So you removed all those facets.
Yeah, there's 3 of them, and this scar it was very difficult, and it's a big guy, so that makes it even more difficult. But it went well. So remember during the surgery after 6 hours, I always say things to Erin, just to bother her a little bit because we work. I bother her like I would bother a friend. I was like, "You think this is going to make his pain go away?" What would you say? You said no, right? I think you said no.
I would never have said no.
Oh.
You said I don't know. I think.
I said I probably what I said is I really hope so.
Yeah, you said I hope so. That's right. You said I hope so. Right. So this is the so I got a post-op. This is the CAT scan just to check screw placement. The only screw that was not perfect was the left L1 screw, which was just slightly lateral to optimal, right here. But it's not in the spinal canal, and it's in the body. It's acceptable. So basically, the next day, he stood up. And he says pain's gone, leg pain's gone. And then for the first time I saw him as a normal human being. He was just walking with his walker bent forward very slowly. And I thought that's his baseline. That's now he's back. Now he's not doing jumping jacks or running marathons, but he's to his baseline now. He can walk with his walker slowly. So his pain completely went away. Which I was surprised actually because his pain was so incredibly severe, but it just goes to show you that a painful DRG is extremely painful, like just out of control pain, like a broken femur pain. So any questions about this case? I know.
Now, you're technically obese at 270 pounds. How much did that factor into the development of this? Do you think? He's been 100 pounds lighter.
Yeah, let's say if he was 180 pounds. I'm not sure. I mean, I don't see many deformities in 180 pounders, do we?
Would you get less osteophytes?
I mean,
Your pressure equals force over area concept?
his lumbar spine is carrying a lot of weight.
Probably. I mean, I think it's probably a contributor. Although, I have seen thin people come in with deformities and problems. What do you think, Dr. Harold? You're in the spine.
I mean,
You see thin people, right?
Yes, and I think it really matters.
Dr. Harold's a chiropractor, if you don't know, so he sees.
When
You see
I'm
thin people
noticing-
come in?
Yeah, I'm noticing it's really when the pressure started. So if it's kids where they were playing, pee-wee football at 3 years old, and in there, I'm seeing degeneration in, mid-20s, for foraminal narrowing and osteophytes and all of that stuff. So weight, I always tell patients, it plays a factor. It's not the number one cause, but it definitely plays a factor. And,
See, but what you'll see is you'll see a much higher complication rate in the surgical treatment of an obese patient. So someone who has a BMI of over 45, you'll see much higher 30-day complication rate, and you'll see a much higher recurrence rate at 2 years. So what the feds are doing with other procedures is they're saying, you can't have this procedure if your BMI is 45.
Well, let's talk about total knees.
Right, so total joints are the
Yeah.
prototype because it's a very popular operation, and hospitals are being graded now on their outcomes. So if you have a high, recurrence rate, if you have like over 1% revision rate, so big places like Cleveland Clinic and Mayo Clinic, they just tell their surgeons post a case and like the BMI is 45. It's like that case never existed.
Or Kaiser. Kaiser you gotta go get a bypass. You have to get a gastric bypass before you get even considered for total knee.
Yeah.
Say that here? You have
So,
to-
So Kaiser
Yeah.
sends patients first to the dietary nutritional person to lose weight,
Yeah.
and if that fails, then you have to get a gastric bypass to lose 100 pounds before you get your
Okay.
total knee.
Right.
Yeah, I've had patients tell me that.
The patients are okay with it. Some, I mean, not all, I guess. Yeah.
Going back to this case, did you happen to check muscle strength afterwards?
He's firing, so his knee was firing,
Yeah.
and he had 4 out of 5 motor strength. He could bear weight
A
on it.
lot was pain kind of shutting it down. And
It could have been pain, or it could have been
The DRG.
motor. It could have been motor loss. It's hard to say, because a person with well, I don't know how. I mean, like a femur fracture person doesn't fire. Like Doug, like a femur fracture does not fire their quad, right? There's some kind of weird protective reflex
Yeah.
where motor function shuts down in painful conditions. It's gone, but then it comes back once you fix the fracture. So I think that may be the truth with DRG pressure too. It's so painful that the muscle just shuts off.
Yeah. It's anticipating more pain if it fires. So just-
Mhm.
I don't know what the
Shuts
mechanism.
off.
No one knows the mechanism of that. Why motor strength is knocked off with painful conditions. But his totally. He walked the next. I couldn't believe it. He walked the next day.
Now, if you have something, if you're worried there's something going on in the abdomen, you can do a laparoscopy. You've got a little gadget that looks around. There's no similar gadget that somebody's devised to look around, because you had trouble with the imaging working out what was going on. Is that feasible in the future?
yeah, the Europeans are doing spinoscopy.
There are some people that put scopes
They
into
put a
the
scope down
fecal
through the,
sac.
yeah, and you're basically looking at the cauda. They're doing it for they're doing it in foot and ankle and tendons now, tenoscopy. They're putting a scope just in about every place, but the Europeans are doing spinoscopy, it's called.
A Tyner fiber optic
Optic.
fiber optic
Comes up
scope,
through the sacrum
Yeah.
like a
Well,
colonoscopy.
Lumbar, and then
in the midline.
and a lot of these intervention. One of my friends is an interventional radiologist, and they're putting, lines and doing dye studies. Like, there's some guy that's doing it like in the prostate in Italy or something, and they're doing, instead of a TURP or something, they're doing basically like a angioplasty of the prostate.
Just a balloon for the prostate.
The vascular supply of the prostate, apparently, so they're doing it for erection dysfunction.
Erection dysfunction is not from the prostate, is it?
I'm not sure if I want to keep going on this.
Yeah.
I'm just trying to.
Well, no, it's a-
just trying to illustrate.
Pudendal nerves.
Right, I'm just trying to
Pudendal
illustrate.
arteries and nerves.
It's in the belly.
How-
It's
how-
a sympathetic plexus in the belly or a vascular problem.
Mhm.
That's when men lose erection from the vascular insufficiency, right? Or the sympathetic plexus. That doesn't sound like, doesn't make logic, it's not logical to me. Okay,
Well, in
so
matter of diplomacy, would you let the prior surgeon know what had happened?
I didn't.
No.
Why not?
I used
It's
to.
a delicate situation.
No, I used to do that. I don't know, I don't do it anymore. Maybe I'm just too busy, I don't have the time. First of all, it's hard to get a hold of somebody. If I had a personal relationship with this surgeon, which I do with some, I email them, hey, I'm just revising your case, just wanted you to know. But some people look at it as an insult, like,
Yeah.
who are you to tell me,
Yeah, I can
that I
see
made a
that.
mistake, what's wrong? And sometimes they don't even want to go to the surgeon will say, why are you calling me? But they should know that something didn't do well as like a feedback loop.
Yeah.
Maybe I will. The guy's a nice man. I mean, I'm sure he'd probably appreciate it. You think I should?
Yeah. Yeah, I think, I think that it used to be a sort of collegial relationship, like this person came to see me for a second opinion or something, and the guy, that person's crazy, or I told them or something, or stay away from that person, they're a drug seeker or something like that, and now I think we've gone away from that a little bit, and I think
I'll
that,
get it. Once it's just divided.
I think that every now and then it's a fine line between,
Fine.
making it so you're not telling the guy he's an idiot or
Yeah.
screwed up or something versus Just wanted to let you know.
I think the medical legal climate has made us paranoid as doctors.
Mhm.
I think in the institution itself, we all are collegial.
Yeah.
But because we're in the same tribe, but another hospital is a different tribe, sort of. But the tribe of, human beings are tribal.
Yeah.
And because another hospital, we don't feel that they're part of our tribe, sort of. Although, sort of we do, but we lose that as, after we leave residency, orthopedic surgeons don't feel that, what do you think, Doug? Don't you agree with that? Orthopedic surgeons don't feel like we're part of the same tribe after we leave residency. And the farther out we go, we're more as competitors than tribal friends. You know what I mean? I'm talking human interactions now.
But this is a known complication of that procedure that was done 2 years ago.
Yeah.
So
Yeah.
it wouldn't be a big thing.
No, I probably should, but I don't think he would probably care. But, now that you said it, I'll do it and see what happens as an experiment. I'll reach out to him and tell him, and I'll tell you next month what was the interaction.
That'd be good.
All right.
Good case.
Yeah, it's good. So, any other questions? Sorry, it was a technical case, but
How long did you follow up after? So this was how long ago?
yeah, the worst thing for results is follow-up. I haven't seen him back. So the longer the follow-up, the worse the results. So I only saw him walk while he was in the hospital. We'll see what happens long-term.
Yeah.
And you say his quadriceps improved?
His quadriceps went to 4.
Before.
He can lift his leg up off the bed
You
now.
had talked about multiple innervation from multiple levels to the quadriceps. Now, is that redundancy in that, can one nerve allow the quadriceps to function? Or do you need all 3 levels of innervation, of whatever it happens to be?
The only time I've ever seen the quadriceps get knocked off is L3. But I've seen it weakened by pressure on L4 and L2. But I have seen the quadriceps completely gone from L3 pressure. But it's not 100% L3. Does that answer your question?
So it's better to have all nerves innervating.
Right. So when there's something important in the body, there are different things that go into it to make it work. Just so 1 or 2 get knocked off, like anal function, this anal sphincter function. You need, I think, 4 out of the 6 sacral nerve roots from L2 to L4 for your anus to work. So they found in removing sacral chordomas, you can remove 3 of those nerve roots, and people still have anal sphincter function, because it's important to have it. So I think the body has these redundancies in it, in important functions, just like the diaphragms, C2, C3, C4.
Or collateral circulation in the heart,
Right,
that sort of thing.
right, exactly.
I was just wondering, because he's been walking with a walker for a while, if you would compare, he might have compared the other quad. 4 might be his normal. So he might have gotten him back to where he was.
Oh, I bet you if you could put him, his quads probably push 400 pounds. This guy's really big.
Okay.
So for him to walk, he needs a strong leg.
Okay, to carry all that weight.
Yeah,
And he is only 2 weeks post-op today.
yeah.
Okay.
Yeah.
Did
So
you
he
send
should
him
be
to a
in next week.
dietitian? The weight loss?
No, I never do that. I should.
We are postulating that if he didn't have the laminectomy, he wouldn't have had the foraminal compressions.
I don't know. Maybe the foraminal compression was a problem from the very beginning, and that it was partially fixed from the laminectomy.
Yeah, that's
It's unclear.
Straighten out the cause and effect.
Yeah, but the laminectomy could have weakened things, and he further deformed.
Yeah.
I mean, I always hedge things, and I just say it's a combination of factors, but it may be. But I think it probably is. He probably further compressed a little bit from weakening.
Correct me if I'm wrong, but I think you're extra
You're
careful
wrong.
to not sever the nerve endings into the longissimus muscles instead of firing the back, where when you do your stab incisions to do screws, it's to preserve that muscle. If you were to stretch it out over the TPs,
Yeah, the
those
muscles die.
never
The muscles
fire
die.
again,
Yeah,
right?
yeah.
Okay.
That's why I do the stab incision. So if you have these big retractors that push really hard on the muscles die, and people get weak backs.
Right,
So that's the whole point of the stab incisions and doing things through holes.
right.
instead of big retractors.
Stretching it out to the teeth.
Yeah.
So many people.
Because that's what they used to do.
Keep stretching a lot.
That's what they used to do,
Right,
right?
and they still do it, and the
Most
muscles
people- most
never
people
fire
do.
again, and
Yeah.
that leads to the instability, especially if you do just a laminectomy, you don't have interspinous ligament, now you don't have muscles firing, you get close.
Most people do that still, because you can see better,
Right.
and it's faster.
Most
if
people stretch it out.
if you fuse the level anyway, the muscles probably don't need to
Right.
fire out.
That's the theory. If you fuse the muscles, you don't. But I don't know if I don't agree with that. I think if you
Yeah, they-
retain as much
They
normal
go
anatomy,
across the level of fusion probably.
yeah, and I think the more normal anatomy you have, the better in function. But you are right in a sense. But it doesn't matter. Like even if you do the best intentions, the muscles still atrophy and they still scar. The more surgeries you have.
Yeah.
But endoscopy, there's a gentleman in the University of Miami doing inner body T-lifts using endoscopes now, doing total discectomy and indirect decompression. Neurosurgeon in Miami.
That's interesting. Okay, so any other questions or comments?
Where's
Just
this?
a-
This is Prescott. You know Prescott, Arizona? Tuesday, John McCain started his re-election campaign for Senate in Prescott, Arizona. Prescott, Arizona is the former capital of Arizona. It's in the north, and this is the main street. It's really beautiful in the highlands, and it's a real like the center sort of the Wild West. And I was just there last week, Prescott, Arizona. It's very
The mountain that was in the movie.
Yeah,
Ah.
they shot movies there.
shot movies in Prescott. It's very famous. And the other, Barry Goldwater, his family's from Prescott, and he started his presidential campaign in Prescott, Arizona. And when me and my cousin drove out there for an hour, we read his biography, Barry Goldwater. And the only reason I bring up Barry Goldwater is a lot of people are comparing him that he destroyed the Republican Party like Trump is destroying our Republican Party. So that's why we got an interest. And Goldwater was a very interesting man, very pivotal man in American history. 1964, he lost in a landslide to Lyndon Johnson, and I think his family's from Prescott. I mean, I'm not sure exactly. I didn't get into where exactly, but he's a very famous Arizonian and American.
Barry Goldwater.
Oh,
Barry Goldwater.
yeah.
Yeah, he was sort of the